This patient arrives in our dental office saying, my teeth are loose and I got swelling around here, around the tooth number 25, 26 area. Is there something you can do? And that's what we're going to talk about today. What do we do in an advanced periodontal case? Now, this patient has been treated by a periodontist for a number of years. He just moved to our state, wants to get established, and he comes in with this kind of swelling. I want you to look at first at the occlusion. Just take a look at the bite. Now, yeah, he's biting. He's open. He's partially open. You can take a look at that. And you can see how he's occluding here on teeth numbers 25 and 26. And I want to talk about the occlusal balance. I want to talk about the balance. You know, we look at occlusion, we look at bacteria and aggressive bacteria, and we look at calculus. We adjust all three of those together in order to be able to balance a case or get a case to the point where the patient says it feels good and where I say it feels good. So let's look at this occlusion a little bit more. Okay, so now he's partially closed. And I want you to look at this bridge down here. This fixed bridge down here, which, by the way, he says, I've never been able to chew on the fixed bridge. Now, the picture won't be that good, but good enough that you can see. Take a look at the occlusion. Now, he's fully closed. Now, yeah, tooth number 7 is super erupted. That's true. But he's fully closed here. The back teeth aren't taking any force. Picture that as we go through this case. Tell me what you see and what you would do. So there's the FMX. The area of the swelling was down here around the 26, 27 area. And let's go through this a little bit more. This is the panoramic x-ray. This is the capture of our CT. In the panoramic mode, and yes, he's lost a lot of bone support around this distalmost implant, number 30 implant. Let's go a little bit farther. And we'll go through the FMX together. You can see there's generalized bone loss here. Don't forget, he's been a long-term periodontal patient for years. And we look at this, but now let's take a look at what's going on tooth number 7. Not much bone support left there, is there? And don't forget, the back teeth aren't in contact. So now the only teeth that are in contact, or one of the two teeth, and this one's super erupted, also has very little bone support. It wouldn't be unusual for somebody to say, we've got to extract this, but I want you to look at this a little bit differently because we're not recommending that. You can say there's a lot of bone loss here, and you know what I say? Yeah, but there's still bone present here. We'll go across the arch. You're seeing tooth number 8. It does have, 60% bone loss, maybe 50% bone loss. 9, we've got the tail end of it here. You've got the infrabony defect. 10 looks better. And 11 look better. And here's 12, 13, 14. On the lower, yeah, okay, we've got an impacted third molar. We're not going to worry about that. The patient's probably, I think, in his late 50s. And we'll see varying levels of bone loss. Now we get towards the front, and here we are. Crowded teeth, loss of bone almost to the apex on tooth number 26. Yeah, I think that's a problem, don't you? And we go to number 27. Now, 27 does have some bone support. Remember, we want to think not in terms just of how much has been lost, because we think in terms of that, then we're thinking about how much bone has been lost. Oh, he's going to lose his teeth. We might as well extract his teeth anyway. And of course, as you know by now, we are a very large dental implant practice, but we pride ourselves on saving teeth. And here, of course, a periimplantitis. Don't forget, a patient who has periodontal disease, and in this case, severe periodontal disease, is more likely to get periimplantitis, a lot more likely. So we even think more in terms of saving teeth, not less. And there's your a little bit of a distal angular impaction on tooth number 32. Now, the first thing I'm going to do is I'm going to run a bacteriological test. Okay, the brand name of this is oral DNA. Those who've followed us know that I like oral DNA. I've been working with oral DNA for 15 plus years. I like them. And what you're seeing is red complex, orange complex, green complex. Okay, the red complex being traditionally the more aggressive bacteria. TF refers to Tannerella forsytha. Okay, it's one of the aggressive organisms. And what happens is a patient will spit in a cup. We'll send the sample out to Oral DNA Lab, Minnesota, and about 10 days later, they'll come up with this and the antibiotic recommendation. Now, somebody would say, well, you always prescribe metronidazole anyway. And my answer is diagnosis before treatment. Okay, there's some times where clarithromycin may be better, and at least I get that in advance, but I want to know what I'm treating. I do, for comparison later on. I want to know what's going on and what I'm treating, and yeah, we prescribe metronidazole. Let's take a look at the periodontal pocket depths, and you'll see bleeding all over the place. You see the number of, or the pocket depths that are here. It's significant. And you can see over here in tooth number 26, that's greater than 10 millimeters, okay? And so we know that 26 is in a lot of trouble. But remember, we're going to talk about occlusion as well. So let's take a look at the CT scan and see what we can learn from the CT scan. Okay, good bone support there. You see the minimal bone support around the implant in the number 30 area. 28 implant is doing fine. And look at 27. But now take a look right here. We'll look at that more. You know, how much stress is on the few anterior teeth that are touching? Is it any wonder that we've got mobility there? And I'll go over that a little bit more. Okay, so you get the idea. Let's take a look now. And there you're looking at tooth number 7 against tooth number 26. No bone support, right? Or very little, but you still have some bone support at the apex. You still have that right here. You still have that right here. We don't have to give up on that. And don't forget that number 7 and tooth number 26 are not only super erupted. Take a look. The facial aspect of tooth number 26 is right in contact with the lingual aspect. You know, that's quite a wedging force there. By the way, so that was infremitus. And what's fremitus? That means that when the patient bites down, the tooth moves. So when the patient bites down, I can't feel what happens on this tooth, but I can certainly feel what happens on this tooth. The patient bites down, and I feel the tooth move out. Okay, that's called occlusal trauma. When there's periodontal disease there, it's called secondary occlusal trauma. Secondary occlusal trauma means, we've got periodontitis, and then we've got influencing that occlusal trauma. The tooth moves. Now, it's interesting that tooth number 6, you're looking at tooth number 7 there now. Okay, but it's interesting that tooth number 6 also moved a little bit. Why? Remember we looked at that fixed bridge? The fixed bridge isn't in occlusion. So the only teeth that are left that can possibly touch are teeth number 6, 7, and 8 on the right side. That's it. Minimal bone support. Nope. On the front teeth. No occlusion on the back teeth. It spells out disaster. So what do you want to do if tooth number 7 is infremitus? Yeah. And remember, you've got swelling on tooth number 26. What do you want to do? Yeah, do an occlusal adjustment. Take it out of fremitus. And by the way, 6 was in a little bit of fremitus as well, but remember, 6 had some bone support on it. So I don't want to take the fremitus off of tooth number 6 because there's no posterior teeth on the right side to handle the load. I want 6 and 27 touching, and I want 7 and 26 barely touching in order to take care of this occlusal stress. And we're also prescribing the metronidazole. Okay? So we're taking care of the aggressive bacteria. We're taking care of the occlusal component on it. So there we go. And now you're back to the periodontal charts. You can review that once again. Take a look. I didn't even look at this in terms of mobility. Why? I didn't want to wiggle it, number one. Number two, it was actually jammed against tooth number 25. But you can see class 2 mobility on every other one. And I guarantee you, if this was independent, it would be a class 3 mobility there. Certainly tooth number 7 was a class 2 mobility. It's a lot of mobility. And he says, my teeth are loose, It says my teeth are loose. You look at the pocket depth is the PD line here. So go ahead and look at it. Okay. Red means, pocket depth that we don't want to have. And the yellow is pus, and red means, red here means is bleeding when I probe. But you can see the pocket depth, the lingual aspect, just a lingual aspect of tooth number 23. A lot of bone loss. Big pocket there, isn't there? So we treat with antibiotics. And we go back and we treat with everything that we know how to treat with. So that's periodontal endoscopy. Ignore the CAL. This is clinical attachment loss. I should have blocked that out. I blocked it out up here. I forgot to block it out down here. We're looking at pocket depth only. Clinical attachment loss means how much bone has been lost. It's a retrospective feature. It's something we're looking at. How much attachment has been lost, and a lot of attachments have been lost. What we're looking now on is active periodontal disease. Notice the pocket depth, how much that's improved with periodontal endoscopy and occlusal adjustment. And what does the patient say to me at the time of the reevaluation? My teeth are tighter. And then he asked me to replace the fixed bridge on the lower right side. And he has the exact principles. He knows what happened with the bite adjustment. He knows what happened with the bacterial component under control. Now give me a new bridge. So that's where we are in a case like this. Remember, we're balancing. We're balancing aggressive bacteria here. Calculus on the root surface, although Selena said there wasn't much calculus here. This is primarily aggressive bacteria. And we want as many teeth biting together as possible to share the occlusal load. Okay? We want all the teeth meeting. And certainly we want to take care of that stress in the front. We don't want this to happen where the patient bites down and the teeth are moving. And that's what we're doing. Periodontal endoscopy, bacterial control, if necessary with antibiotics. We'd rather not prescribe antibiotics if we don't have to. And get the occlusion meshing properly. So now that we have that, we will see the patient again in 3 months. I'm not ready to replace the fixed bridge yet on the lower right side. Why? There's a ton of bone loss on that implant on the lower right side. We've got to decide whether it's better to utilize that implant or maybe even take out that implant, put another implant in. I'd rather not do that. Let's give it a few months. You can wear a night guard in the meantime to take care of the space, to take care of the occlusal load. We can do anything with a removable appliance, which is relatively inexpensive, before we make the big decision on how we're going to replace the fixed bridge. If the implant number 30, the one that had a lot of bone loss, if that implant number 30 is doing okay, in other words, I probe it, there's no separation, I'll likely say, let's use the implant in this compromised state. Rather than go through an aggressive surgical procedure to remove that implant and put another implant in place, perhaps in the number 29 area. We may even put in a long-term temporary fixed bridge on number 28 through 30. It can be made out of acrylic, long-term acrylic. You can get that from the laboratory, from a nylon type of substitute, and just to see how he does. My goal is, I want him to be able to chew on something. My goal is to take the stress off the anterior teeth. And so we can do that with a long-term temporary. It has given us the opportunity then to get the teeth in occlusion, to get the bridge in occlusion with the teeth that have a better bone support on the upper arch, and take the stress off the posterior teeth. And maybe we can defer that decision for a year and just see how stable the implant is on tooth number 30 before we make the next decision, which is to put in new custom abutments and a fixed bridge, which is more expensive. You get the idea, okay? This is a balancing act. Periodontal disease is a chronic degenerative disease. It has occlusal components to it. It has aggressive bacterial components to it. And it has calculus there as well. We've talked about that in other videos. Any questions, any comments, go ahead and put them in the comments section. Happy to respond to that.